prescribe exercise. Now, this was the same patient, right, for all of this, but you're not going to give them 5 different areas. That's, you know, then that ends up being like 6 hours of exercise. So obviously, based on what their primary issues were, you're going to pick and choose, prioritize, and just give them a couple. All right? Okay, next area on your sheet to actually also work with fatigue are energy conservation and work simplification. So this is task analysis, right? Task analysis that you kind of worked on last year a little bit when you were breaking down movements, but it also can be used to somebody in their day. So this is a population that if they're having issues with fatigue, you want to say, tell me about your day. You want to know what transpires over their entire day that maybe contributes to them having fatigue or endurance issues. Remember that this also may be a population that has some subtle cognitive issues. So as much as you think, well, they could probably problem solve that, they may not be able to. So helping them to problem solve through things that seem to be a little bit more tiring or causing the fatigue could be helpful. On the last 2 pages of your handout is just a simple kind of task analysis work simplification worksheet that gives you sample questions that you might ask a patient to help them do that analysis. So that's certainly another area that you might address. I often get caught up in this with families that I work with. Like I want to give the family stuff to do at home, and I forget to say, wait, how many other kids do you have, and what else is going on in your life? You know, before I give them a whole big block of things. So, but this is certainly a population where I want to make sure I check in with that. Okay. All right, we're going to move on from fatigue. So if you turn the page over, you have a case. It says case 1, part 1. So this is a patient with relapsing remitting multiple sclerosis. And what I'd like to do is to kind of have you read over this and then together as a group come up with a problem list and then things that you would like to assess in your objective. And then we'll actually have you do it and try to kind of synthesize the results a little bit. So everybody read through that. Case 1, part 1. Falling that. What else? Fatigue. What else?
Maybe strength, just as her legs give out.
Yeah, so legs kind of giving out. There's something kind of going on there. What else? Anything else? Yeah.
I don't know if it's too much of an overlap, but decreased endurance.
Yeah, I think it's kind of, you know, I think that there's a community endurance piece that might be different from kind of that everyday fatigue. I would agree with you. Good. So I would agree. So what do you want to look at? What do you want to assess in your objective?
Balance.
Balance, yes. What else?
Endurance, like how far she can walk.
Agree? Yep. If I want to get a measure of that, what else?
Let's hear to the stairs. She talks about
So
the
maybe
stairs.
a functional, something maybe a functional, certainly. What else?
Manual muscle test your legs.
Yeah, I think so, right? Why not? So what's about this? Let's go back a sec. So I would absolutely agree. When you think about strength and endurance and maybe even fatigue, is there anything in the subjective that says, you know, is it due to the disease pathology or something else? Do you see any other behavior going on there? Yeah.
I was also curious, this is just like, because I don't know, but the medication stuff, I looked them up, and it's like, if that could be something to address, or like,
Right. So I would say, I would certainly note that they're on those medications, and as I go through my assessment, kind of factor in, does that play into it? Yeah? Yeah.
She sits most of the day at work, so she's sedentary.
Yeah. So is there any other behavior that tells you she might be self-limiting?
She stopped walking as much.
Yeah. So there's some cues in there that says, you know, I've got some issues here, but I'm also got some behavior that, is it truly that, or is she self-limiting? Right? So there's a little bit of self-limiting stuff kind of going on. I would agree. Good. What else do we know about this disease? Oh, Billy, go
Well,
ahead.
I was just gonna add, if you think self-limiting might be an issue, you might do like the ABC just to determine like how confident is she in her ability to
Yeah.
actually get around.
I would agree. I would agree. What else do we know about this disease that could potentially, especially go into here? Yeah.
I would probably check sensation.
So sensory and what else?
Cognition.
Cognition. What else? Another big one.
Vision.
Vision. Now I don't have anything that's jumping out at me though, do I? So if I was going to maybe put, I might, in my back of my mind, I'm thinking sensory, vision, but I think those are going to be lower down. I may not go there on this visit unless I pick up something else. Does that make sense? Because there's nothing jumping out at this objective with me. Good. Okay. So with your partner, I actually want you to assess these. Okay. So there are patient scripts up here in the white. So whoever's going to be the patient first, you pick up a script there. What I want you to do is I want you to pick a balance assessment. Let's pick absolutely do strength, and then I want you to look at a timed test here, and not the 6-minute walk. A timed test here. Once you do those assessments, see if you can make any conclusions about why this person is falling, having fatigue, or having endurance issues, okay? And then, where would you start with intervention? Where would you start with intervention? Okay? Strength? More so than balance?
Yeah.
Did strength play into balance?
Yeah.
Do you think you can get this person stronger? Why?
She might have some like learned disuse.
She's what?
She decreased her activity.
Yeah, she's, again, we go back to that self-limiting thing. If I'm trying to make a decision based on, do I think this patient can improve in an area, and I see some of that behavior saying, well, they've stopped moving. You bet I'm going to try to see if I can get this person stronger. Absolutely. So that's probably where you're going to start, right? But we said our primary issue was falls. So if strength is impacting falls, that's going to happen overnight where that's going to get better, right? So we've got a period of time before it affects that. What do you think about an assisted device for this patient? So what's the purpose of the assisted device? Because it's not balanced, right? Yeah. Shoot. Yeah.
Could the assistive device be a tool to get her out in the community so that she feels safe? 'Cause
So she felt safer?
she's self-limiting because she was embarrassed about her falls, so that would by itself increase her activity, but then you want to make sure that she didn't get too attached to it.
Yeah.
People would usually get rid of it.
Or if, first you gotta see if she'll buy into it, right? You got that part too. I agree. I mean, that might be worth a try because she is falling, right? And we do want to increase her mobility, but I think we need to be a little reflective and go, wait, what is the purpose of this? If it truly is, if the issue is strength and I'm asking her to lug something around like a walker, am I only contributing to it? And there's some research that says more energy goes into using assisted device than helps. So again, if it does come out where it actually gets her moving more because she's comfortable, she was afraid of falling, this makes her feel more secure, well then yeah, maybe I give her one for a while. And I start working on that strength. Does that make sense kind of in that clinical decision making?
Mm-hmm.
How often do you want to see her? What do you think? Yeah, because she's falling, right? I probably want to err on the side of probably you're seeing her more early on. One, because that program to address the strengthening is going to take some tweaking. I'm going to have to really figure out what's going to work for this patient, and I got to get her safe. So I might be playing around with the assistive device. So this might be the patient that I see twice a week for a couple weeks, and then I start to gradually decrease that. And probably my goal is going to be around falling. Yeah.
I just got out a question. So when you're reading through this history and it says the last exacerbation was 12 months ago,
Yeah.
and we know that usually it's kind of about one a year, so when do you consider that she might be kind of losing some function because of that?
Sure. I think it would have to go with, I would probably ask like, you know, like that fatigue scale, was it more acute?
Okay.
Are these, so it's going to be in that history of how long things are going on. If it's not though, if I don't think it's an exacerbation, I also think, wow, that's been a long time since that. That gives me a more hope that I can actually get this patient stronger. So it could go both ways.
Okay.
I agree with you. I would ask more questions about, Has anything really changed in the last couple weeks? You notice any development just in that short period of time? And then I would be more concerned with that. Agree, absolutely. Okay? Yeah.
So how do you like balance doing that stuff in clinic versus having her get more involved, like at home doing ADL activities or getting her more active while she's at work? Like, how do you determine when to add that stuff in?
Right. I think that it's got to be something that and that kind of goes to that exercise prescription, is that I can give her an exercise. I need to know how it affects the rest of her day, how it affects the rest of her week. So there's a lot of patients like this that you might do like a log-in, like for a whole week, a log that says, when did you have fatigue? Then that's going to help me know when can we start increasing those other things at home. Or could I even at this point go, okay, that task is hard. Doing the laundry is hard. How do you do it? Is it downstairs? Is it upstairs? Do you want to do it? Yeah, I want to do it. Okay, let's figure out a way for you to do it. And then I might do some of that work simplification. So that's why, again, that to me points more towards, she's limiting in ADLs as well, some other things there, that I'm going to see her more often early. And then taper off if need be. Okay? All right, now a more complicated one. Let's look at the next one. This is the same patient coming back. I think it's a year later. Look through that. Let's do the same thing. Let's come up with a problem list and then what we want to get objective measurements from. Oh. Do they feel different than over there? Yes. Did you have any reason what you did over there to go to sensory, to go to vision? No. Do you have reason here? Yeah. So what's going to be other things? Problem list, vision, right? What's the issue with vision?
The world bounces.
The world bounces. Gaze stability. What else? Yeah, there's some sensory things going on there too, right? I'm going to lump those kind of together a little bit. Anything else, problem list-wise? Strength, I mean, we don't know, right? I mean, it certainly could be something that it might be of concern. I think you guys are doing an awesome job, that these are probably my priorities. Great. I probably could keep going on this with endurance and fatigue down here as well. But this is certainly my big thing that I got to answer this question. Why is this person falling? All right, what do you want to assess?
Would you also be worried about like the pins and needles thing?
Yeah, so I'm going to lump that into sensory.
Okay.
I agree, yeah. So what do you want to assess? You're going to get objective measures. Vision, what are you going to start with? I think a screen. I would certainly want to start with a vision screen before I go to like dynamic. Agreed? All right, so we're going to do vision. Probably a screen first, but then I probably got to get to this dynamic piece. What else?
Like the proprioceptive, you could do like the active angle reproduction.
Right, so I probably want to tease that out. I want to maybe look at the assessment. Do I want to do anything first before I even look at proprioception, sensory? Do I want to do a balance thing that maybe kind of weights that a little bit, gives me objective, right? Everybody agree with that?
Yeah.
Right, so I might want to do something that gets at this balance piece first, and then I'm going to tease out proprioception and sensory. Does that make sense? Okay. Switch roles. Patients, PTs, we're going to look at this, this, and this.
Why don't we just start in general? So what would you say based on your assessment? What are the main issues? What did you find? Gaze stability, gaze instability, right? So gaze stability problems. And what led you to that? Yes, so doing the DBA. At 2 hertz was impaired, right? Okay. So there's an impairment of the VOR. Okay, so what else did you guys find? So proprioception issues. So what did you guys find on the CAT-SIP? What were the findings? Look at Ashley. I know you just want.
You take a stable you take the stable surface away, they really have issues.
Yeah.
Eyes open or closed.
Yeah, so what happened? So when they closed their eyes on a firm surface, they fell after 10 seconds. So what does that tell you?
Relying on vision.
So maybe they're relying on vision, and maybe they have proprioception, but maybe they're not using it. And then when they go onto foam, they fall, right? So we know, and then your follow-up from that. So if you did the modified CAT-SIB, and then you're wondering about proprioception. So what did you find on proprioception testing?
It's absent from the big toe down.
Okay, so Chris is saying it's absent in the big toe down. What's down from the big toe?
Well, big toe to L5 and on was abnormal.
Okay. So let me go to this. So with this patient population, do you expect dermatome loss? No. So not dermatome loss necessarily. So we're looking more specific joints. And so with proprioception, Karen talked about how she typically tests ankles first. Judy typically tests toes first. And this is a patient population you work distal and go proximal. Okay. So if you looked at big toe, it's absent. So they couldn't tell you. But at the ankle, what did you find? What's that? Intact. It's intact. Yeah. Yep. And so the most basic proprioception testing is, did you feel me moving you? And then, is it up or down? And kind of go from there. And you'd found that everything proximally was intact. So what does that tell you? So they tell you that you test it, and proprioception, they have it, but what are they not doing? Yeah, they're not using it. So going on with the next kind of problem, so it's impaired proprioception, right? Or it's intact, but they're not using it. So there's a problem with integrating sensory systems. So for this patient, I would actually say that patients at risk for falls due to gaze instability and then impaired sensory integration. So they have different sensory systems, they're just not using them together. And then so that's that whole picture that kind of puts it together with this patient. So what are you going to do? Like, what are your interventions? What are your priorities? BOR times one for gaze instability. Yep. And as we talked about in more of the vestibular labs, we start to train the VOR. And if for some reason after a few sessions you're not getting anywhere, then what do you go to? Let's say they're progressing to a point that this is impaired enough.
Substitution.
Yeah, substitution. Using a different system potentially. Okay, so VOR times one, what are your other exercises or retraining you're going to do?
Kind of like working on ankle strategies. So we talked about like swaying next to the wall, where you're doing anterior, posterior, medial, lateral, working on regaining ankle strategies.
Yep, so starting to use proprioception. Yep.
You could start at the hip and then work back to the ankle, since they only had a step, but.
Yep, that makes sense. And then what's different from this patient's fall perspective with this case versus that first case? And what I'm kind of looking at is function, and would you give them something today?
Surface dependent. I don't know if that changes anything.
What do you think about assistive device?
She's holding onto the walls and furniture.
She's using
kind
a
of
rolling
telling you
chair.
she needs a walker, right? And there's enough here that, like, this is, from day one, I probably am gonna, say, for safety, you're already using things to walk with, we're gonna go to a walker. So this is a little more cleaner of why assistive device might make sense. So that's probably one of the first things I do. How often are you gonna see this person?
Pretty often.
Pretty often, yeah. So I'd say 1 to 2 times a week to kind of address some of, especially VOR, doing proprioceptive kind of training and assessing for falls. So you're going to see this patient a little bit more often and maybe a little bit longer. So going back to the sensory finding with the burning after you did sensory testing, what do people think that's all about? What would you call that? How would you document that? You ever heard term allodynia? Yeah. So you could say this, it's like a delayed onset. We also talk about dysesthesia.
Yeah.
Because it's
More
that.
like a weird processing of it.
Yep.
Yeah, that's usually.
With some patient populations, the minute you touch, they have pain. This is a delayed onset. So this has to do more with the underlying pathology with the demyelination, that you have that delayed response that happens. So that's how I kind of label that. Any questions? This is a hard case. It's a lot to pull together. I agree.
What I like about this case, though, is the idea of like you kind of start big and then start to get narrow. And the decisions of, I get to something and I'm thinking it's not there. Oh, it's there. What does that mean? And giving you a place to start. So it's a good example of that. And certainly fairly common in this diagnosis, where you have to really tease out those components.
All right.
Okay?
Nice job.
All right, so you ready? Remember on Thursday we'll have